Thank you for joining me. I'm Juan. Today we're going to be discussing basic operations of the LTV1200. Basically, how to set it up for your patient. We'll also review volume versus pressure and AC versus SIMV. It's going to be a good review. You're going to want to watch this video. Okay, so let's quickly review volume versus pressure. So let's define volume first. By definition, in volume control modes, the tidal volume is the defined variable which is used by the ventilator to give feedback in the valve circuits. Volume and flow is pretty much linked. The volume control modes are generally constant flow modes. The ventilator delivers flow which is constant and stops this flow when the desired volume is achieved. So because of that, you see the waveform, you see the parabolic sloping and the shape as the lungs distend during the breath. Let's look at here. We set, for example, let's say we have volume AC, we have 14 breaths per minute, tidal volume of 500, PEEP of 10. The breath is initiated. Once it's initiated, the volume comes in, flow comes in, the liters per minute, and the flow stays stable. Pressure increases as the volume increases. And once you hit the desired volume, which is 500, the tidal volume stops and pressure drops and flow comes out. The pressure waveform is highly variable during volume control ventilation, changing shape depending on lung compliance and airway resistance. It has to adapt according to lung compliance and airway resistance, but the tidal volume is going to stay the same. There's some advantages. The biggest advantage is being able to control minute ventilation, which we'll discuss, and we'll also review some of the advantages and disadvantages. But let's move on to pressure. Before we move on, you see here this line represents 500 tidal volume that's set and is constant. Keep that in mind. Pressure, let's define pressure. In a pressure controlled mode of ventilation, the inspiratory pressure is the control variable and is maintained during the inspiratory phase. As a result of this, the pressure waveform is square. This increases the mean airway pressure, the area under the pressure. This increases the mean airway pressure. So during the inspiratory phase, the ventilator provides high inspiratory flow rate. We have here the high flow rate to achieve the pressure limit variable and whatever we set the PIP at. In order to maintain the pressure, the flow rate needs to decrease over the course of inspiration, and it generally takes the shape of downsloping ramp. So we see here the downsloping ramp. If the inspiratory time is long enough, the flow will eventually reach zero, as demonstrated in the graph here. When the flow rate reaches zero, in the absence of flow, the constant prescribed pressure is the equilibrium with the peak alveolar pressure at the end of the breath, and it equals the plateau pressure. Okay, so, but we see here the tidal volume will be the variable depending on the lung compliance. We set the PIP and the tidal volume is going to adapt according to the compliance. What are some of the advantages? You have increased duration of alveolar recruitment. Pressure limited ventilation may protect against barrel trauma, and that's one of the most major things. It protects against barrel trauma. So let's review some of the advantages of volume control. You have guaranteed tidal volumes produce a more stable minute volume. The minute volume remains stable over the range of changing pulmonary characteristics. And we're going to review minute ventilation, which is the biggest advantage of volume control. Some of the disadvantages: the mean airway pressure is lower with volume control ventilation. Recruitment may be poor in lungs with poor compliance. In the presence of a leak, the mean airway pressure may also be unstable. Now let's look at pressure. Some of the advantages: increased mean airway pressure, increased duration of alveolar recruitment, protective against barrel trauma, work of breathing and patient comfort may be improved. And some of the disadvantages of pressure: tidal volume is variable and dependent on respiratory compliance. Uncontrolled volume may result in overdistension. Let's look at minute ventilation, which is going to be the biggest reason that volume is preferred, because they have control of minute ventilation. And it's the biggest advantage of volume control. There are some cases where pressure is more appropriate, but we're just going to review minute ventilation. So what is minute ventilation? Minute ventilation is tidal volume times respiratory rate. And why is this important? Because sometimes we need to calculate how much CO2 we need to exhale to make this sick patient healthy. So in order to do that, we need to have an appropriate minute ventilation. Now, minute ventilation sometimes is calculated by gender, height, weight. We're not going to discuss how to calculate minute ventilation. But let's just say we have here our patient and they need a minute ventilation of 8.4. In order to achieve that, we have the patient set at 14 breaths per minute. If we have the patient set at 14 breaths per minute, then we know that they need 600 of tidal volume. So how do we know that they need 600 of tidal volume? Because 0.6 times 14 equals 8.4. And that's one of the biggest advantages of minute ventilation. We can't come up with these calculations with pressure. Again, there are some cases where pressure is more appropriate, but this is where volume shines. Let's quickly review AC versus SIMV. Okay, so if we take a look at this chart, we see that the first breath in this cycle is initiated by the ventilator. Okay, so this first breath is initiated by the ventilator. How do we know that? There's no negative deflection. The second patient is triggered by the patient, and that's the reason for the slight dip, the negative pressure. The ventilator senses this and delivers another breath. The user can set what the trigger is in liters per minute of flow, for example, to make it easier or harder for the patient to trigger the breath. The ventilator will then deliver that breath to the set volume or pressure depending on the parameter set by the user. It is pressure controlled or volume controlled ventilation. So whatever you set it at, in AC mode, it's going to reach those parameters to whatever you set. The ventilator assists the patient by controlling the amount of volume the patient receives. Now, let's look at the chart for SIMV. Just as in AC mode, if the patient does not trigger a breath, the patient will receive a set volume or pressure, as in the first breath here. There's no trigger. However, in SIMV, when a triggered breath is initiated, the patient determines the volume, which may be smaller than the non-triggered breath. If the patient wants a lower volume during their spontaneous efforts, they will receive a lower volume. If the patient takes good volume during their spontaneous breath, this may indicate that weaning might be possible. If spontaneous breaths are too small, then pressure support can be added to each to help the patient breathe. So that's the quick difference between AC and SIMV. What are some of the advantages and disadvantages? Well, SIMV may lead to more work of breathing is one of the main things. So if we have a patient that has poor week of breathing and is not able to trigger some of these breaths, it may be more appropriate to keep this patient on AC. Now let's take a look at the vent and actually look on how we can set these parameters up on our vent. Okay, so assuming you did the leak test, and we have video 1, which you can refer back to for the leak test, and your vent is ready to go, I suggest you get a glove or use a test lung and set it up before you actually put it on the patient. So the first thing you want to do is and it's going to ask you same patient or new patient. So you scroll up to new patient. Then it's going to ask you infant, pediatric, adult. So we'll select adult. Okay, so any alarm, you hit silent. Let's lower the tidal volume here. So I'm using a pretty small test lung. That's why it's going to be high pressure. Okay. So now you set it up. If you want to change anything, you just click on it and scroll up or down. And all the blinking that you're seeing on the video, that's because of the camera. That's not how it's going to look on the vent. So let's say we want this patient up to 14 breaths per minute. Tidal volume 210. Have the eye ties set. O2, you can go up to 100%. I'm out of oxygen, so it's at 21%. And let's see, PEEP here. 3. Okay, so how do I know it's on volume? Down here is the options for volume and pressure. If I hit once, it blinks on pressure. Hit it again, it's on pressure. Hit it once, it's on volume. Hit it again, it's set on volume. And we already discussed the difference between volume and pressure. And if you want to change AC versus SIMV, the option's right here, right next to it. That's how we set up volume. That's how we set up pressure. And it has a constant rotation of different settings and what's actually being administered. If we look at here, the tidal volume says 211. One thing to remember that there are going to be times where some of the space in between the vent and the tubing, some of the tidal volume is going to get lost, and you'll actually see a different tidal volume, maybe a lower one than what you originally had set. So if that's the case and the patient is symptomatic and there's obviously some issues and you're troubleshooting, and you see up here that it tells you that actual tidal volume being administered, let's say we have this one set at 210 just because I have a small test lung. Anything higher is going to set off alarms. But let's say you had the pressure, let's say you had the tidal volume set at 500, and you see on the display 420 is actually being administered. It's like here, you see 188 was being administered, but we're asking for 210. Well, you're going to have to kind of adjust the difference. So I would start off with, if you wanted to administer 500 tidal volume and on the display only 410 is being administered, then I would increase it by 90 and see if that does the trick. So go to 590 and see if we can supplement for that to give us the desired amount if the patient requires it. So I keep seeing 188 being administered. So I'm going to increase it by 22 to do 232 to see if that changes what's actually being administered and kind of supplements. And you'll have to play with it. You see there at 210, it jumped up to 210. And that's what I desired. I initially set it for whatever I set it for initially, and we had to increase it to get what we desired. So keep that in mind during your troubleshooting. Remember, when you're troubleshooting, you can think of the mnemonic DOPE. So displacement, make sure that displacement is make sure wherever the patient was intubated at the teeth or the lips that you're maintaining that. Also, O for obstruction. So let's say your patient needs to be suctioned. Check that out. Make sure your patient doesn't need to be suctioned. Pneumothorax. If there's signs of pneumothorax, you may have to needle decompress. Or equipment failure. It's possible that there can be equipment failure. So some alarms that you may see that may lead you to think there's an issue with the vent itself. Low battery might be something, and there's external batteries on this. Make sure they're fully charged. You can press to see how many bars. And then there's an internal battery. If you just have it set on the internal battery initially, if the outside batteries die, you're probably going to get a battery alarm. It's fine. Just reset it twice and make sure you charge it as soon as you get a chance. One way that you'll definitely know if there's an issue with this vent, if an alarm comes out that says INOP, inop, it basically means that it's inoperable. If this alarm goes off when you have the patient on the vent, and INOP, then you need to remove the vent from the patient, bag them, put them on a auto vent, a backup vent or whatever, and send it back to the manufacturer. Another alarm you may see a low O2 pressure alarm, and that may require you to increase the O2 inlet pressure. If you're using an O2 cylinder, you may have to replace it with a new cylinder. Low PEEP. This occurs when the PEEP is less than the low PEEP alarm setting, and some solutions for that, you may have to disassemble, clean it, reassemble the the PEEP valve. Low pressure. If you see a low pressure alarm, make sure everything's connected. If you see a high pressure alarm, make sure there's nothing kinked. If you see an oxygenation issue, pulse ox is low, you may want to increase the PEEP, increase the FiO2. Let's say the end tidal is extremely high, you may want to increase your breaths per minute. Maybe give the patient a sodium bicarb drip. Let's change the patient to pressure. Click here. And now the patient's on pressure. We have the breaths per minute. We've changed the patient to pressure. Now we set here the PIP. Let's see, PIP is here 12. Okay, let's put them back on volume. Press it once, it blinks. Press it again, they're on volume. And let's say they're in SIMV. You see the pressure support comes off. This is if you want to give them a little bit extra, just in case they're not able to meet the required settings. Does have a manual breath option. Those are the basic functions for volume, pressure, how to get between AC and SIMV. I would suggest reading the user manual, also completing all the courses, but this is just to give you some basic understanding, basic foundation on how to set your settings. And you're going to find that every time you turn off this vent, the alarm goes off and stays off until you hit silence. So we turn the alarm off. That's going to keep going on. So you just press silent. Thank you for watching. Please subscribe, like, and share, and see you on the next video.